So first I'm going to introduce to you guys Amanda Galambos from faraway Saskatchewan. And she's going to be talking about using a virtual classroom to build HIV and HCV capacity in Saskatchewan. So Amanda, I will give you have 10 minutes and I will give you a warning at 1 minute.
Excellent. I'm going to share my screen here. Beginning. Okay, starting my. Okay, good morning. As mentioned, I am joining you today from Saskatchewan, which is located on Treaty 6, which is the homeland of the Métis. So I'm going to talk today about a project that I coordinated. It was administered by a nonprofit organization called Saskatchewan Infectious Disease Care Network. So this is an organization who's made up of the infectious disease care specialists. So again, those are the physicians, the specialists who treat HIV and hepatitis C. We received 4 years of funding from Public Health Agency of Canada, and the project just ended on March 31st. So our issue here, and I'm sure it's similar in Manitoba, is that our province urgently needs more treatment providers who are physicians, nurses, to treat our patients. Why? Well, since 2011, at least, our province has had the highest annual rate for HIV and hepatitis C, as well as co-infections. In fact, our new numbers just came out for 2021, and they are the highest by far than they've ever been, with significantly less testing happening. We've also have unique transmission trends in Saskatchewan, injection drug use being one of them, when women of childbearing age who are more susceptible. We also have a very, very, very small number of infectious disease specialists. I believe there's under 10 for the entire province. So despite having the largest number of patients per capita, we just don't have enough specialists. So they need help from our primary care providers to help deliver care to patients. So our solution was we created an education program that delivered continuing medical education. Even before the pandemic, our vision was to use an online platform to help reach participants from all over the province. Our approach, here we go. So all of our presenters were local. So they were here in Saskatchewan, working frontline. They were specialists, and they were primary care physicians, nurse practitioners, and peers. So they were seeing firsthand the issues. We showcased local data and transmission trends. We discussed clinical guidelines, best practices, and we emphasized what needed to be done to manage HIV and Hep C here in Saskatchewan. So, which medications are being used and whatnot. We highlighted where to go, how to contact, who are community-based organizations, harm reduction services, etc. So just helping our learners, again, remembering these are the doctors and the nurses, know where to go, what needs to be done, and how to do it. And the foundation of all of our teachings was emphasizing the importance of non-judgmental and stigma-free healthcare. So we spent a lot of time during all of our presentations talking about strategies, discussing the importance of trauma-informed practices, reconciliation, and whatnot. And again, because what we were seeing in Saskatchewan was unique, we had to create our own medical education. We couldn't just use things that were created outside of the province. Our participants weren't finding it helpful. So that, again, was our strategy. So this just sort of briefly kind of just shows the different topics that we discussed. So we had an HIV virtual classroom, which was 8 hours of medical education delivered over 4 sessions. That was very successful. And then we expanded into hepatitis C, which was 4 hours. And then our participants were saying, well, we need more, one-time presentations aren't enough. So we used our platform of that online virtual classroom to deliver specialty one-off presentations. And you'll see here at the bottom, we addressed our ongoing syphilis outbreak by creating a new syphilis virtual classroom. And in that one presentation alone, we had 124 primary care providers attend. There was actually 200 that registered, but only 124 attended live. So when it was all said and done after our 4 years, we were very pleased that we reached so many providers from all over the province. For context, this here is Saskatoon and this is Regina. So this is about a 2.5-hour drive. So if you think of that physician or nurse who's way up here in the tip, by having this online and virtual, it just removed a lot of barriers for participation. We found that our participants really liked our programming, with quite a large number coming back and attending almost 2 or more, sometimes everything that we threw at them. They were very eager to join and get this information. Previously, it wasn't available, and it wasn't local. So our primary care providers were left with growing numbers of patients, but not really knowing what to do or how to do it. So our sessions provided them with a basic knowledge, and also what labs to order, how to interpret results, how to engage care, and whatnot. So it was much needed in this province. Another highlight on the impact was that we were able to recruit a lot of new treatment prescribers. So these are now physicians or nurse practitioners who are designated prescribers, meaning that they have the ability to prescribe HIV and hepatitis C medication. And if you take a look, they're located all across the province. So this it's just a win for the patients, who can now get access within their communities. They don't need to travel. And again, just decreasing the need to see the specialists for cases where they don't need to be seen. Our programs were all evaluated, and they were all well received. So nearly all indicated that the information was useful. It improved their medical practices. And then we followed up with them several months down the road to be like, what did you do with that information? And we were very happy to see, again, really high percentages of our graduates saying that they used this information. They increased testing, they were more confident talking about harm reduction, they made more referrals. So that was all the results we would like to have seen. And just some recommendations, some things that we found our participants like, was using case-based scenarios so that are relatable. They resonated with our learners. These were made up situations, but they were representing what we are seeing here in Saskatchewan. And using, again, our local medical experts. So we had the specialists teaching the physicians, so they were colleagues to colleagues. It helped the specialists learn who was out there that was interested in this work, and it helped our primary care providers know who to contact when they were coming across challenging cases. Best practice always is including people with lived experiences. So we used peers as development, so they developed subject matter for us, but they also presented. It was extremely beneficial having someone with lived experience talk about what it's like to receive an HIV diagnosis, what considerations that a physician should have as they're delivering that, or if they're trying to engage their patients. And there is an ongoing need, so there's a need for ongoing education. So one presentation simply isn't enough. So just, thinking of ways to make opportunities available. We really found it, if you built it, they would come. So we would, absolutely. So we would, throw out new topics and they would fill up and people would come back again and again. So just remembering that once is not enough. And we offered our presentations before and after clinic hours, usually at 5:30 p.m. And online was what our primary care providers preferred. So just again, removing any of those barriers for participation. This is it. That's me. I welcome any questions. You can contact me in the future if you ever want to discuss my project or just generally as TBVI and medical education. Thank you for having me, and I look forward to learning more today.
Thank you very much, Amanda. That was a great presentation. We all appreciate it. Now, moving forward, there goes no one. Now, the next person I'd like to introduce is Dr. Albert McLeod from Two-Spirited People, Manitoba, and he's going to be talking about the national surveillance of people who use drugs. Albert, you have 10 minutes, and I will warn you at one. Thank you.
Thank you, Ken and team. I'm just going to go into my slides here. And slideshow. And so I was part of it. I joined a team of people who were involved in the national project with PHAC, Public Health Agency of Canada, to look at injection drug use. And so our team joined, and this was the Manitoba survey that was done here. And the track studies initially about maybe 8 years ago were Aboriginal, MSM, IDU, and John Kim, do you remember the other one, the track studies? And they were kind of all consolidated into this general track project. So there were other track studies in the past, but again, they've been the facts focusing, it's called Phase 4. And it is a national survey with people who inject drugs. So it's a trigger warning. We are talking about injection drug use as well as some of the drugs that are used by people who inject drugs. So when the survey took place in Manitoba, Treaty 1 territory, as well as the homeland of the Métis Nation. So the acronym is PWID, people who inject drugs. It is focusing specifically on Manitoba. So among females, people who inject drugs were was the most frequently reported risk category for 36.7%, followed by heterosexual sex, endemic risk, and then among males, people with who inject drugs who engage in heterosex were the most frequently reported categories, 23.5%, followed by MSM at 2%, and endemic risk 8.8%. So now this is the HIV just a surveillance update from Manitoba for 2020, and that was released in December 2021. So we see in terms of injection drug use and sort of the transmission of HIV among injection drug users in Manitoba. So the hierarchy of risk exposure categories for HIV, you will see again under males, men who have sex with men, and then secondary, people who inject drugs, men who inject drugs. And then for females, it is the principal reported route of transmission for females in Manitoba, injection drug use. So the survey was conducted from January through April 2019 with 181 participants surveyed. Cisgender women, 76, cisgender men, 96, and the other genders, 9. 82% of the participants were identified as Indigenous. 134 participants provided a dried blood spot sample for HIV and HCV and HIV testing. So the lessons learned, participants in the study have hope and spirituality. They belong to families and they contribute to their communities. These strengths support coping with unjust social and colonial conditions and toxic drug markets. This project highlighted the imperative to implement Indigenous oversight in local studies and demonstrated possibilities and challenges when implementing a national surveillance survey. Recommendations point to local responses that address underlying social inequities, Indigenous wellness, and cultural identity and rights-based reconciliation. And the team was myself, Leah Much, Paul McLeod, Marcia Anderson, Dr. Marcia Anderson, Shelley Marshall from the Regional Health Authority, and then Sarah Day Shaw from the University of Manitoba. Our community lead was Jenna Wirch. Now, in doing this analysis, and again, when we developed the survey questions, FACT sent us a template, but we sort of amended or adjusted the questions for Manitoba's population. So here's what the infographic looks like. And this infographic was shared at the CAN conference this past week at the Fairmont Hotel. And thanks to Shelley Marshall, who and the team helped put this together very quickly. Sage Gibosh was also part of the team. So again, it shows the breakdown. Again, a majority Indigenous people who participated in the study. And then we looked at, including, in terms of employability or employment. So the last 6 months, 19% worked full-time, 23% worked part-time, 66% have received social assistance, and 6% were students. So part of the way this infographic is developed is to address some of those sort of systemic stigmas around people who use drugs, and particularly injection drug use is still very stigmatized in Canada and in Manitoba. But again, wanting to position that people may use drugs, but they also work, right? They also pay taxes, they also raise their families and contribute to society. Now, we positioned in the infographic not to jump into the data as the foreign part of the information sharing. We want to focus on some sort of social determinants of health, local characteristics around beliefs in spirituality and resilience. So we put this at the top, second part of the infographic, and the message about hope, belonging, meaning, and purpose. So these were some of the questions that we added to the national survey specific to our population. And these are the results. We asked questions about, their reason for living. So I believe there is a reason the Creator gave me life. I have a necessary role in my family. I recognize that I can contribute to my community. I know that all of creation has spirit caring for me. So again, with 82% of the respondents being Indigenous, this we felt was very important to share with anybody who's reading this data, this research report, to show that, people may be using alcohol and drugs for recreation or to cope, but it doesn't mean that they do not have a spiritual or, ethical or cultural center to their being. Then we went into more, in the infographic, more details about drug use and injection drug use. And here you have, a comparison between 2006 and 2019 of the drugs that people injected in the last 6 months. So you see an increase of crystal meth, decrease in crack, and then looking at the opioids, you see an increase morphine, oxycodone, hydromorphone, and then looking at the increase in in terms of street opioids, like fentanyl, heroin, and down, right? So fentanyl making its way into the community here in Manitoba. And we know that because there's been many overdose deaths last year in Manitoba. I think it was up 85% according to the Manitoba Harm Reduction Network. So again, this idea of the poison drugs coming into Manitoba is having a real impact. So what's helpful? 74% of respondents said they would use supervised consumption services, and we know there's been great resistance in Manitoba by different sectors, particularly our governments, to that actually happening. Participants found traditional activities, drumming, sweats, crafts, recreation, sports, art, music, and harm reduction supplies helpful. Then access to healthcare, only 10% of participants had a regular healthcare provider. About 1/4 of the participants avoided health services in the last year. to fear or concern about stigma from staff or neighbors, concern that someone might learn to use drugs, or police harassment. Now, we also undertook the dried blood test, and sometimes with research projects, sometimes this does happen and sometimes it doesn't. And I know in the early Aboriginal track in Regina, they did do testing of respondents, and they found a few that assumed they were HIV positive, and then they found some who didn't know they were HIV positive. So 9% tested positive for HIV, 36% had a hepatitis C infection in their lifetime, and then 48% of those with a history of hepatitis C infection had active infection, right? So with the Hep C, there is this issue, or that there is effective treatment available. So there's a real gap here. Recommendations: support Indigenous-led responses and services for substance use that build on community strengths and race-based reconciliation. Improve access to culture-based supports and coping mechanisms, safe and dignified housing options, access to harm reduction services, including supervised consumption services, gender-sensitive services, and support to prevent injection issue.
Albert, you have 1 minute.
Great, thank you, Ken. I'm just in my last thing. So we added to the infographic some access sites for anybody reading it where they could get information or supports, community supports. And then at the bottom, we identified who undertook this study and that it was a project of the Public Health Agency of Canada. And I'm done.
Thank you very much, Albert. That was a lot of information, but a lot of good information.